Jack West, MD. I'm an associate clinical professor in medical oncology at City of Hope Cancer Center in the Los Angeles area, and also founder and president of GRACE. Isabel, can you tell us who you are and what you want?
Sure. My name is Isabel Preeshagul. I am a thoracic oncologist at Memorial Sloan Kettering, and I am very excited to be here today speaking to all of you.
And Joan.
Yes. Hi, everyone. I'm Joan Schiller. I'm a medical oncologist living now in Northern Virginia. I was formerly the deputy director of the Cancer Center at UT Southwestern and also of the Shar Cancer Center in Northern Virginia as part of Inova.
Excellent.
I'm glad to be with you.
Let's turn to the setting of advanced metastatic lung cancer, where one of the presentations at ASCO that got some real attention was in a pretty controversial setting of patients with with a low level of PDL-1 expression. PDL-1 is a protein on sometimes on cancer cells, and when it is present, it tends to be associated with a greater chance of patients responding well to immune therapy given to stimulate the immune system to detect and attack the cancer. And essentially, we tend to break down the level of PDL-1 expression as negative or less than 1% of cells having it, low, 1 to 49% of cells having it, or high, 50% or more cells. And it's almost a third distribution of patients out there who have low, negative, low, or high. It's about 40% of patients in this low category. And one of the real challenges is that there are a few ways to treat patients with low PDL-1. There's a common FDA-approved approach of giving chemo for 2 cycles combined with immune therapy, and that immune therapy could be a single drug of Keytruda, pembrolizumab, or there's a combination called Nivo or nivolumab and ipilimumab, or that's Opdivo and Yervoy. These are all FDA approved, and they're approved as a combination of these drugs with chemo. And for patients with 1 to 49%, there's also an approval for Keytruda alone or Nivo and Ipi together without chemo to be done. And so this study from the FDA looked at the data from the various studies that had looked at these combinations to try to get a sense of whether an approach with chemo or without chemo was a better way to go. And this showed essentially that progression-free survival and overall survival were better in the data when chemo was included with immune therapy. These curves are called Kaplan-Meier curves, and essentially they show how a population of patients are doing over time as time goes from right to left. And so the drop represents patients who either have the cancer progressing or die of cancer. And so when there's a gap and a curve on top, that's the group doing better. And you can see that the general numbers are better for the group in red, that is immune therapy combined with chemotherapy. So I'd like to get a sense of what you think about this. There was also a subset. They looked at different groups and saw that patients who were older had comparable results whether they got chemo or not, 75%, 75 years or older. And so, I would just ask broadly, what does this mean to you? What was your approach before this? Does this solidify? Does this change anything for you? Starting with you, Joan, if you can comment on, what's your view been looking at the totality of the data?
Well, you have to recall that one reason why chemo has been added to these immune inhibitors in this particular setting is because these patients with the the 1 to 49% don't do as well with immunotherapy alone as those patients who have very high levels of PDL-1. So, and the whole reason for combining with chemotherapy was to hopefully bring those patients with the intermediate PDL-1 up, and it clearly did. Most of the studies that have been done looking at this all show that patients in that interim group, 1 to 49%, do better with the combination of chemo plus immunotherapy than they do with immunotherapy alone. So I think many of us have been using the combination of chemo plus immunotherapy in that group of patients. And I think this really just kind of confirms it with higher numbers, frankly.
And Isabel, what's your perspective? Were you on the fence, or did you clearly have a preference for chemoimmunotherapy in this low PDL-1 group?
I think I was definitely convinced by the Keynote 189 data, and much like Joan said, I think that that it's just nice to see, always nice to see what your thoughts were and what your practice was reconfirmed with larger numbers or longer time periods, and that the patients feel better about that, which is the most important thing. Anytime we have long-term updates, I know that if it just reconfirms what we know already, it's discussed but not discussed as in detail as the new data. But this kind of stuff is the most exciting to me to share with my patients, because patients that are on this therapy or benefiting just love hearing that you know, there's more data or there's more evidence to show that this was the right choice for them and they're doing well. And I love sharing this kind of news with patients.
Well, that's great. I had actually, one of our colleagues, Charu Agarwal from Penn, had referred to these data as practice affirming, which I think is an apt statement. But I think, you know, there's some who, whether they're patients or oncologists, who are always hoping to sidestep chemotherapy if you can. And I think that while you are permitted to do that, there are options that would allow that. This would really suggest that the patients are not necessarily best served by that. That's really been my view, that if feet to the fire, I would say there's a clear superior choice if a patient is willing and able to do it.
Right. I would agree entirely. And I think you do have to have that discussion with the patient, but you have to make sure they know that they're less likely to do well if they just choose immunotherapy alone.
Great.